webinar series are also on both the AST YouTube channel as well as the TDRA. So if this is your first time joining us, welcome. We hope to see you again in the future. And if it isn't your first time, welcome back. I wanted to share with you a little bit about the Alzheimer's Society of Toronto. So we service the whole M postal code area, and we provide free counseling, education, programming, and information to people living with dementia, care partners such as family members and friends. We also do training with healthcare professionals, as well as general public workshops. Some things that we do want you to note is that even though we are called the Alzheimer's Society, we service all dementias, and that you do not need to have a diagnosis or a referral from a doctor in order to access our services. You can self-refer, and we will provide support from pre-diagnosis all the way beyond. Some of the ways that we are currently providing services include through Zoom. We are offering some face-to-face services now, and we also have our e-learning platform, Educate, where you can also access some education. For more about what we have happening, please feel free to visit our calendar of events that's listed on the website below. I'd now like to tell you a little bit about our partner, the Toronto Dementia Research Alliance. Established in 2012, the TDRA is a collaboration among the University of Toronto and affiliated academic hospitals, including Baycrest, the Centre for Addiction and Mental Health, Ontario Shore Centres for Mental Health Sciences, Sunnybrook Health Sciences Centre, Unity Health, and the University Health Network. TDRA is working together to better understand, prevent, and treat dementia by creating a stronger link between basic science and clinical research, embedding research into care, improving outreach and education to the community, and increasing the efficiency of collaborative research processes across the city. I'd like to now hand it off to Natalie to tell you a little bit more.
Okay, thanks, Julie. Could we just move to the next slide? Great. So part of this partnership and what this webinar series centers around is the Toronto Dementia Network, or TDN, which is a website that lists dementia-related programs and services across Toronto. And on this website, TDRA and AST created a section called Research Studies, which lists dementia studies that are open for participation across the city. So each study listed is led by TDRA-affiliated scientists and has been approved by a research ethics board. There are studies for people with Alzheimer's disease and other types of dementia, mild cognitive impairment, those at risk of developing dementia, and as well as healthy volunteers and caregivers. The studies are all summarized in plain language, and to get started, the website link is shown here in orange. Information about the TDN can also be found on the AST and TDRA websites. We can go to the next slide. Okay, and on the website, there are two main pathways. First, you can browse for a study using search terms, filters, and quick searches. And when you find a study you're interested in, you can fill out the contact form to be connected with the research team who will enroll you in the study if it's something you are eligible for. Or at the bottom here in gray, if you're not sure where to start, you can fill out a questionnaire to be matched to a study, and any information you enter anywhere on the website will be securely stored and protected. And next slide. Okay, so this is what the web page looks like when you're on it. If you just search Toronto Dementia Network and not research studies specifically, you can get to the research section by clicking the tab along the top right, which is circled in that red box. When on the page, if you're looking for something specific, for example, Alzheimer's disease, or you know the name of the study you're looking for, you can type it in the search bar along the top. You can either hit submit with that term alone or apply more filters like the type of study, the age group, the study location, and then hit submit. Alternatively, you can use the quick search buttons we have in the blue boxes. If you'd rather fill out a questionnaire to be matched to a study, you can click Match Me to a Study in the quick search box in orange, Or if you scroll to the bottom of the page, you'll find another orange box that says can't find a study you're interested in, and that will also take you to the questionnaire. And each study summary, as shown in the NABIT study example on the left, describes what the study is about, who can participate, the location, and the time requirement. Again, that's all in plain language. And next slide. Okay, great. So I'd now like to introduce our speaker. Before I do, just a reminder, Julie said to enter any questions you might have in the chat box, and we'll answer them at the end in the question and answer period. You can also unmute yourself and ask questions that way. So we're grateful to be joined today by Dr. Krista Langtoat. Dr. Langtoat is a senior scientist in the geriatric psychiatry department at Sunnybrook and in the Hurwitz Brain Sciences program at Sunnybrook Research Institute. She is the research co-director of psychiatry and the head of neuropsychopharmacology research. She is a full professor of psychiatry and pharmacology and toxicology and the vice chair, basic and clinical research in psychiatry at the University of Toronto. Dr. Langtoat also holds the permanent chair in geriatric psychopharmacology. So welcome, and we look forward to hearing your presentation today.
Thanks so much for that introduction, and then just bear with me while I try and share screen so that I can start. It's always, it always takes me a bit. While I'm doing that, just thanks to the TDRA and the Alzheimer's Society of Toronto for organizing the study so well so that people can find local studies that they might be interested in. So let me do. There, ready. Okay, so today I'm going to be speaking about exploring novel drug treatments for agitation in Alzheimer's disease. What I thought I would cover today was mostly some background about agitation and its treatments, and then a little bit about the rationale for the two studies that I'm going to be speaking about, and let you have a link so that you can find those studies on the TDRA website. So first of all, to get us ready, this is not going to come to be a surprise to anyone, but dementia is an umbrella term used to describe a range of symptoms associated with cognitive impairment. So it's a syndrome. This cognitive impairment can be manifested as memory loss. By the time you have dementia, this can be noticed by someone else in speaking with you, word finding difficulties or difficulties communicating, difficulties with visual and spatial abilities, for example, maybe getting lost while driving, difficulties with reasoning or problem-solving tasks, difficulties handling complex tasks, like, for example, doing your income tax when you've done it in the past, and difficulties planning and organizing, for example, being able to sew something from beginning to end. And the key feature here is that it's a decline from your previous levels of functioning. So if you always got lost when driving, like I do, then you have no room to decline in that. So I thought I'd start with a little poll for our group to answer the question, what is the most common cause of dementia?
Results are all trickling in, and it looks like the majority of people are selecting Alzheimer's disease, roughly 81%. We have roughly 14 that have selected vascular, and then another few that have selected frontal temporal dementia, but the majority is on Alzheimer's disease.
Okay, and just for housekeeping, that means, Julie, are you going to end the polls?
Yes, I will.
Okay. So there's the results. I have to go back to this. All right, here we go. So just to show you that you're exactly right, Alzheimer's disease, dementia, is thought to account for 60 to 80% of cases. That's followed by vascular dementia, 10 to 40% of cases, then Lewy body dementia, 10 to 25, and frontotemporal dementia, about 10%. So Alzheimer's and vascular are the most common. What's interesting now, though, and is becoming more apparent, is that a lot of patients have more than one pathology when you look at their brain. So mixed dementia, having more than one pathology, is found in about 50% of people, it's been estimated, who are presenting with dementia. So the two most common, Alzheimer's disease dementia and vascular dementia, actually together account for 80% of cases. So we do see a lot of mixing as well. The landmark study was just released by the Alzheimer's Society of Canada in September 2022. And it's been estimated that in 2022, over 600,000 Canadians are currently living with dementia. You can see from looking at the graph that I put on your right-hand side here, that that was based on almost 600,000 in 2020. But in the next decade, by 2030, we can expect this number will reach close to 1 million persons with dementia. That's right now there's about 124,000 new cases every year. And with the aging of the population in the next decade, we're expecting 187,000 new cases per year. And that will be 21 more people diagnosed with dementia every hour. So dementia is very common in Canada, and we're expecting its prevalence to increase. The reason for that is the aging of the population. We all have the #1 risk factor for Alzheimer's disease dementia, and that's age. Age is the #1 predictor of whether you're going to have Alzheimer's disease dementia or not. As you can see from this graph that I have here, in the decade following 65, about 1% of people can be expected to have Alzheimer's disease. By the time you're 75, that increases to about 7%. And in the 85 plus group, 1 in 4 people are expected to have Alzheimer's disease dementia. So after the age of 65, the risk of dementia doubles every 5 years. And after the age of 85, 1 in 4 Canadians will be diagnosed with dementia. So I've told you that dementia is diagnosed in Alzheimer's disease based on cognitive deficits. So the ABCs of dementia are activities of daily living, behavior, and the cognitive deficits. The cognitive deficits are accompanied by changes in activities of daily living or function, and that's the A. But today we're going to focus on the B, the behaviors or neuropsychiatric symptoms. I'll call them NPS throughout the presentation. It's a heterogeneous range of psychological reactions, psychiatric symptoms, and behaviors resulting from the presence of dementia. So for the next poll, I'd just like you to guess or tell me your experience, what proportion of persons with dementia have at least one of those neuropsychiatric symptoms?
Okay, the results are still coming in, but we have roughly 40% who are guessing 90, similar amount for 70, and then for 50%, we're looking at about 20% of our participants who are thinking that this might be the case, and then finally for 30%. We're looking at 6. So the majority are leaning towards that 70 to 90% range. I'll just show the results that I'm seeing.
Okay. And then I'll close it so that I can keep going. So You're exactly right. Neuropsychiatric symptoms are very common in Alzheimer's disease. This particular graph shows one of the earliest studies, 1996, when neuropsychiatric symptoms were first defined by Jeff Cummings and his group. And as you can see, here are the neuropsychiatric symptoms. They include the most common, apathy, in about 70% of patients, and then followed by agitation, anxiety, irritability, and depression that are found in 40 to 60% of persons with dementia, followed by aberrant motor behaviors like wandering, disinhibited behaviors found in 30 to 40% of patients. And then the least frequent are delusions and hallucinations, the psychotic symptoms, but those are still found in about 30% of persons with dementia. Overall in this study, just cross-sectionally, 88% of persons with dementia had at least one of these symptoms, and it's been estimated that over the course of Alzheimer's disease, almost everyone will suffer from one of these neuropsychiatric symptoms. So even though they're not part of the diagnosis, they're certainly part of the reality of living with dementia. Today, we're going to be focusing on agitation in Alzheimer's disease. In this particular study, it was found in 60% of people with dementia, but let's look at some of the other data for this. First of all, there is a definition for agitation and cognitive disorders. It's defined as excessive motor activity, verbal aggression, or physical aggression. And key to this definition is that the behavior has to be consistent with emotional distress. You could say that a marathon runner has excessive motor activity, but it's the difference between wandering and being agitated to have the emotional distress. So it's an expression of someone's emotional distress. And it also has to be severe enough to cause excess disability before it's considered clinically significant agitation. Why do we need a definition? It's because it's a syndrome of behavior. So it's a group of different symptoms, just like dementia is. And in order for a medication to be prescribed or something to be researched, you need a definition that everyone can accept. So this is the definition for agitation and cognitive disorders that has been accepted in the last decade to best define agitation. So agitation is common in Alzheimer's disease in a variety of care settings, starting first, people with mild cognitive impairment. So in that pre-dementia state, about 10% of people will have agitation. And if they do, it predicts an increased risk of conversion to dementia. By the time people present to memory clinics, about 15% of people will have agitation. If you look at all people with dementia living in the community, about 30% of those will have agitation. And by the time you have moderate to severe Alzheimer's disease, it's been estimated that 20 to 50% of those with moderate to severe Alzheimer's will experience agitation. So it's definitely common throughout the disease. One of the biggest predictors is severity of cognitive impairment. So you can see from the graph that when you're in the very mild stage, about 10% of people, 13% actually on this graph, of people will have agitation. By the time you move to mild Alzheimer's disease, though, you have an almost 5 times increase. The odds of having agitation increases 4.5 times. And by the time you're in moderate to severe compared to very mild, you have a 6 or 7-fold increase in the number of patients who have agitation. The other thing is that even though agitation is not there constantly, it's episodes of agitation. Once you have agitation, it tends to be very persistent. This graph shows time in months and the NPI agitation score. So this is an agitation score. And in the same group of people, you can see that the agitation score slowly increases over the 3 years of the study. At baseline, having any agitation was found in 52% of people, and that slowly increased over 3 years to being found in 60% of people. And having a score of at least 4, which would be consistent with a diagnosis of clinically significant agitation, was found in 15% of participants at baseline and increased to almost 1 in 4. So these cases in green are the severe agitation that would need treatment. Agitation has a negative impact on persons with dementia and their care partners. For example, for persons with dementia, it's been associated with a strong decrease in quality of life, with health problems such as weight loss and falls, with functional decline, so loss of activities of daily living, and with an increased risk of death in some studies. For their care partners, it's been associated with increased caregiver burden and an increased risk of early institutionalization. Once patients are institutionalized, agitation is also a principal concern in nursing homes, even for professional care staff. So for treating agitation, first line are always non-pharmacologic interventions, for example, psychosocial interventions. And a review by Jill Livingston et al. Of 160 studies proved that various activities can help reduce mild to moderate agitation. She found that music therapy and sensory interventions were the best. For example, massage, therapeutic touch, and multisensory stimulation. The majority of these studies were done in long-term care facilities. She also found, though, that there was evidence lacking to prove that there were significant long-term benefits and that no benefits had been demonstrated for severe agitation symptoms. So next, treating severe agitation. The next step for severe, once psychosocial interventions are in place and any medical problems have been ruled out, are drugs or prescription medications. The drugs that are used for Alzheimer's disease, such as the cholinesterase inhibitors and memantine, do not improve agitation once it occurs. It may help delay emergence, but once it's there, it doesn't really help decrease the agitation. Atypical antipsychotics, the medications that were developed for schizophrenia, are commonly used, and they do work, but they have modest efficacy. So they don't cure agitation, they just decrease it a little bit. And they can be associated with severe side effects in some persons with dementia. So currently, there's an unmet need for the treatment for severe agitation. To summarize, for non-pharmacologic interventions, they have limited efficacy for severe agitation, and they're very difficult to implement in long-term care facilities where you have a whole bunch of different staff. And for pharmacotherapy, we still haven't found the perfect medication that has the balance that we're looking for of safety and efficacy. So now I'm going to move on to the first study that we want to talk about today and give you the rationale for the use of cannabinoids. Cannabinoids, as I'm sure you're aware, is the pharmacologic term for drugs that are related to cannabis or medical marijuana or marijuana used recreationally. So marijuana has two major components, THC, tetrahydrocannabinol, and CBD or CBD oils, cannabidiol. So THC is the major neuroactive component in cannabis. So it's the major component that works on your brain. Clinically, we know that we can see following THC a calming effect, which is dose related though, and can also turn into too much sedation. We've seen anti-anxiety effects with THC. We know that they can increase appetite. Appetite loss can be a big problem in people with advanced Alzheimer's disease, particularly those who are suffering from agitation. They don't sit long enough to actually finish their meals. And pain can also lead to agitation. So THC, when given as a medication, can help decrease pain. Second thing is that we know that THC can actually help with brain health compared to the atypical antipsychotics that are associated with an increased risk of death. THC helps with a whole bunch of pathological processes that occur in Alzheimer's disease that can contribute to brain cell death. For example, neuroinflammation. Inflammation in the brain is associated with Alzheimer's disease, and it helps with that, as well as mitochondrial dysfunction. Your mitochondria are the powerhouses in the cells in your brain, and it can help with that. So it helps with mitochondrial health. It's been hypothesized that a breakdown of the brain's natural cannabis system in Alzheimer's disease dementia leads to loss of neuroprotection, and that can help support Alzheimer's disease dementia and make it worse. So should everyone, based on this, go ahead and try it? Well, of course not, because everything, like I showed you with the balance, is a balance between efficacy and safety. And we know there can be some safety problems with THC as well. Given in too high a dose, it can cause sedation, even treatment limiting sedation, which can lead to falls. It has been associated with decreased memory, so it can contribute to cognitive impairment. So you don't want to take someone who has some problems with cognition and give them a drug that's going to make their cognitive impairment worse. It has been associated with some withdrawal reactions, and you have to be careful about drug interactions, especially when you're using high doses of THC, or if you're on a medication that has a very narrow therapeutic window, like warfarin. So in 2019, we published the first pilot study of nabilone for agitation and Alzheimer's disease. Nabilone is a synthetic or man-made version of THC. It's available in a pill that can be taken orally. It starts to work within about 30 minutes, and its duration of action is 8 to 12 hours. So you can take a pill twice daily of nabilone, and it's already available on the market. It's been marketed for nausea and vomiting associated with chemotherapy. We ran a small trial in 38 patients who had agitation and Alzheimer's disease dementia. And we ran a crossover trial where we looked at the efficacy and safety of nabilone versus placebo. In this crossover trial, each participant was given nabilone for 6 weeks and placebo for another 6 weeks, and their order was randomized. So you either got nabilone first and then placebo, or you got placebo first and then nabilone. So each participant acted as their own control, and every person in the study had a chance to receive both nabilone and placebo. So this shows the agitation change during nabilone and placebo. Here on this graph, we have an agitation scale, the Cohen-Mansfield Agitation Inventory. Higher scores mean more agitation, lower scores mean less. And as you can see, at baseline, 2 weeks, 4 weeks, and 6 weeks, we measured agitation every 2 weeks. Placebo's in orange. It stayed fairly steady throughout the course of the trial. But in the nabilone phase, in these same people, their agitation scores went down. If we look at that another way and look at percent improvement, this graph shows a proportion of patients who had minimal to marked improvement. As you can see in this first one, nabilone's in blue, placebo's in orange. 47% of patients improved during the nabilone phase and 23% improved during the placebo phase. So there was a greater proportion of patients improving on nabilone. For the no change category, there were more participants who had no change receiving placebo. And for the people who declined during the trial, there was a greater proportion of people on placebo who declined compared to those on nabilone. Other findings in this study that favored nabilone are overall behaviors. When you're giving a medication and you're targeting one behavior, one thing you want to do for safety and quality of life is to make sure that you're not making any of the other behaviors worse. So for tetrahydrocannabinol, THC, one thing you might be concerned with is making psychotic symptoms worse. So we were careful about recruiting patients for this study who didn't have psychotic symptoms at baseline, and we didn't find that psychotic symptoms got worse. So overall behaviors, in fact, got better. We did a second scale with participants that looked at agitation aggression, and that was also significantly lower, which makes it less likely that finding it the first time was a chance finding. Caregiver distress was improved, and cognition was improved by a tiny little bit. That's important because the other medications that are given for agitation tend to make cognition a lot worse. So even improving it by a tiny little bit at least shows us that we're not making cognition worse. For tolerability, there was way more sedation during nabilone compared to the placebo phase. And that's partly because of the way we ran the study. We didn't know exactly which dose to use, and we wanted to individualize dose. So we increased the dose up to 2 milligrams per day, unless we got sedation, and then we backed down on the dose. So a lot of those patients developed sedation, and then we would back down on the dose. There was no difference in treatment limiting sedation statistically, but as you can see from the numbers, 5 people had treatment-limiting sedation during the nabilone phase, and only 1 person had it during the placebo phase. There is no difference in falls, serious adverse events, study discontinuations, or deaths during the trial. So based on those promising data, we're now running the NABIT trial that I'd like to talk to you about today. NABIT stands for Nabilone for Agitation Blinded Intervention Trial, or NABIT, and it's supported by the Alzheimer's Drug Discovery Foundation. And you can see the list of investigators. It's a bunch of investigators who are actually from the Toronto Dementia Research Alliance, led by the Sunnybrook team. So based on the evidence that I just showed you, before you would recommend this to be given clinically and before you would prescribe it widely, you would need a larger and longer trial, because this is a short trial and each participant acted as their own control. But we only have data in 38 patients around the whole world, and that's not enough to change practice. We need a larger and a longer trial. Importantly, it's multi-center. Typically, when you move some of these trials out to different centers, you want to make sure that your center wasn't biased and you're not the only center who finds it for some reason. Before it can be prescribed, you have to look at it in a bunch of different centers with a bunch of different people. It's going to be randomized again so that we can say whether the drug is working over placebo, and it's important that it's placebo controlled and masked. So the drug and the placebo will look exactly the same. We're aiming for 112 patients with a clinical diagnosis of Alzheimer's disease dementia who meet criteria for agitation. We'll give either 1 to 2 milligrams of nabilone or placebo over 9 weeks. And we'll also be looking at biomarkers potentially related to agitation and related to response. It's important for individualized medicine that we analyze trials and try and figure out who has the biggest chance of responding. This study is being run at 5 sites. 3 sites are in Toronto, 1 is in Whitby, and 1 in Calgary out west, and recruitment is ongoing. Just to show you on the right-hand side, we have 27 participants enrolled to date. So we're just over 20% enrolled. So we'll be running this study for the next few years. For eligibility, there's a big, long, page of inclusion-exclusion criteria. So just getting to the hardcore inclusion-exclusion and not some of the nitty-gritty. Participants have to be 55 years of age or older. They have to have a clinical diagnosis of Alzheimer's disease. They have to have agitation that happens regularly and is of concern, so at least moderate or severe. And because they're part of a clinical trial, they have to have a care partner who accompanies them to study visits and is also willing to participate in the study. For the time requirement, we're looking at 9 visits that happen approximately every 2 weeks throughout the study. And we do have provision for some study assessments to be completed remotely, so just telephone call or Zoom. For information about the NABIT study, you already heard from Natalie how you can access the website. It's being run by TDRA study investigators, so it's available at Sunnybrook Health Sciences Centre, at CAMH, at Ontario Shores, and at St. Michael's Hospital. And those are the investigators. At our site, you contact Kritleen Bawa, who you can reach through the TDRA website, or just by emailing nabit@sunnybrook.ca. The other reason that it's important to look at medications related to THC is just the fact that medical cannabis use is growing among older adults. And this is data that was collected by my postdoctoral fellow, Dr. Tamati. We looked at data from October 2014 until October 2020 from a medical cannabis provider. And these data were in almost 10,000 older adults, here defined as people at least 65 years of age. The mean age in this group was 73 years of age, and females were about 60% of users. And you can see from the graph from 2018 to before that. You remember that cannabis became legal in all provinces in October of 2018 for adults 18 years of age and older. So before that, the older adults comprised almost 18% of people who were using cannabis through a medical cannabis provider. But after it was approved, that proportion rose to 31%, and even during COVID, about 23% of older adults, of people using cannabis were older adults. So that proportion of older adults is actually increasing. When we asked people just by survey why they were taking it, the primary indication was pain in almost 68% of patients. They also suffered from some adverse events. Even the people who came back and said that they were still using it, they said that they had dry mouth, drowsiness, which can be a problem, and dizziness, which can also lead to falls. They did report, though, that they had improvements in pain. 73% reported improvements in pain, 65% improvements in sleep, and 53% reported statistically significant improvements in mood compared to having a worsening or no change in those symptoms. So we are seeing a big increase in medical cannabis use among older adults. So it's important that that use, especially in people with Alzheimer's disease, dementia, is supported by actual clinical trials that show whether it works or not, and in whom. Now the rationale for the use of citalopram, the other medication that I want to speak to today. It was based on an earlier study with a different drug called citalopram, the Citalopram and Agitation trial, or the CITAD trial. The design of this study was they recruited people who had agitation and Alzheimer's disease dementia. Everyone was given a psychosocial intervention plus either citalopram in 90 patients given at doses of 10 to 30 milligrams per day, or placebo. Citalopram is an antidepressant that is commonly used. It's a serotonin reuptake inhibitor. And they found significant benefits on agitation. In that study, 40% of people who received citalopram plus the psychosocial intervention improved, versus 26% of people who received the psychosocial intervention plus placebo. Unfortunately, with this medication, they found a significant worsening of cognition over the trial and some concerning cardiac symptoms that were picked up on EKG, called QT interval prolongation. It's a finding if your QT interval gets too long, it can mean that you're at risk for your heart stopping. So they also found that response was heterogeneous. So citalopram was more likely to be effective only in a subgroup of patients. Outpatients, they ran both outpatients and people in long-term care facilities. And in this study, only the outpatients responded to citalopram. And if the patients were too cognitively impaired, which is the population who tends to have agitation, they also didn't respond. So the group who were least cognitively impaired were the ones who were responding, moderately agitated, but not severely agitated, and within the middle age range of their population, which was 76 to 82 years of age. So they found that only a subgroup responded. So based on the significant benefits for this trial, they're moving to citalopram, which is a sister drug. The CITAD trial stands for citalopram for agitation in Alzheimer's disease. And it's actually a study that's sponsored by the National Institute on Aging, and the principal investigator is Anton Thorstensen down in the States, but it's being run by a variety of sites here in Toronto. So citalopram is an antidepressant that's related to citalopram. And you can tell by the name, citalopram is a mixture of two moieties or enantiomers. They're called the S enantiomer and the R enantiomer. So it's like having left hands and right hands together in a basket. They look the same and they're kind of the same clinically, but they don't necessarily fit your right-handed glove the same way. It's the same with these drugs binding to receptors. So citalopram is just the S enantiomer, so just one hand. So they went through and purified it and only took out half of the medication, which you can do if it becomes important. So what they found previously was that the S enantiomer, so the S part, was the one that was associated most strongly with a responsive agitation, and the R part was the one that was most strongly causing the cardiac side effects. So that's why there's hope that citalopram will still have the efficacy or the effect that they found and not have the safety problems that they found. So that's citalopram. So CITAD is a randomized, again, we're randomizing people so that we can stay masked, and randomizing them to either matching placebo or drug in a 24-week clinical trial. Again, they're looking at the efficacy and the safety of citalopram plus psychosocial intervention in those who don't respond to a psychosocial intervention alone. So everyone gets a psychosocial intervention. If your agitation improves and you no longer have clinically significant agitation, you would stay on the psychosocial intervention throughout the trial. If your agitation doesn't improve, then you're randomized to either citalopram or placebo add-on, and still the psychosocial intervention and the counseling continues throughout the trial. So the psychosocial intervention has three components: counseling, the provision of educational materials, as well as a 24-hour availability in a crisis situation. Citalopram will be targeted at 15 milligrams per day, and it can be given as a single dose in the morning. They're aiming to recruit almost 600 participants with Alzheimer's disease, dementia, and clinically significant agitation or aggression. So to spell that out a little more, who can participate in this trial? A clinical diagnosis of Alzheimer's dementia. And when I say that, I mean that you don't need a PET brain scan to prove that you have amyloid beta, or you don't need a special blood test using Simoa to prove that you have amyloid beta. It can just be your regular clinical diagnosis that a physician would make. They have to have symptoms of frequent agitation and aggression. Again, they have to have a care partner who spends at least several hours per week with the participant and would be willing to accompany that participant to the study visits and would be willing to participate in the trial, because the study partner also has some forms to fill out. And they would have to be available for 6 months of follow-up. The time requirement is 6 in-person visits, 2 to 3 hours each every 3 weeks, and 7 telephone contacts over 6 months. Each visit is assessments of mood and cognition, questionnaires, blood work, and heart monitoring, as well as psychosocial counseling that continues throughout the trial. So for more information about the CITAD study, I have the QR code that will be available at the end of the presentation, and it's being run at CAMH, Ontario Shores, and Sunnybrook. So last polling question: what proportion of persons with dementia with agitation receiving placebo will benefit? And these are the people who were in the clinical trials. So it would be people with severe agitation. I'm sure you can tell that the next question and the last question that I'm going to answer in this presentation is just like, why do we need placebo, and do we really need placebo?
Results are still trickling in. The highest portion is 25%, 37% of participants are saying about 25%. I'm actually going to end the poll so you can actually see the results yourself as well. So it's real mixed in terms of what people are thinking.
So we have a spread, and most commonly 25%, which shows that you're paying attention, because in the 2 trials I presented so far, 25% in both, even though one had a psychosocial intervention and the other didn't, and they were different lengths, 25% of people benefited just from being in a clinical trial, regardless of what therapy they received. But I want to show you something, because in those trials, there was a difference between people receiving the drug and the placebo. So in those trials, you'd say, well, the people receiving the drug do benefit more. And that's true in that case, but I want to show you some data of why we need a placebo. So first, concentrating on the top one, these are data from the 12-week Harmony study that evaluated a drug called scitalopram that's no longer being developed to treat agitation. They looked at 350 persons with dementia who had Alzheimer's dementia. And as you can see here, placebo is in this orangey color and the drug, which was scitalopram, is in blue. Over the 12 weeks of the study, the placebo group and the drug group both responded to treatment. They both had the same change on a scale that looked at agitation. So there was no efficacy over placebo, and there's a decline in agitation in the both groups. So if all you had was a drug group, you would say that the medication is working because agitation is going down in these treatment-resistant patients. But really, in this case, it was from participation in the clinical trial. So that was Salloway in 2014. So does that still happen? Or, you know, have we changed Alzheimer's disease dementia treatment of agitation so that participating in a trial no longer helps? Well, here's a 2021 study. It came out in October of 2021, so less than, almost a year ago now. This is the 12-week SIMBAD study that evaluated mirtazapine, which is a serotonin norepinephrine reuptake inhibitor, which the only reason I'm telling you that is because it's very related to citalopram and escitalopram. It has half of the mechanism plus another mechanism. They all impact serotonin the same way, but this one also impacts noradrenaline, another brain chemical or neurotransmitter. So you might think it would work based on what you saw from the citalopram trial. So this was looking at mirtazapine for agitated behaviors in dementia in 204 patients or persons with dementia who had Alzheimer's disease dementia. There was no efficacy over placebo. This time the colors are switched. So the placebo group is in blue and the mirtazapine group is in orange. So the placebo group is actually doing a little bit better than the placebo group. There was no difference at the final visit between placebo. And in fact, in this population, in this particular study, the placebo group did better on quality of life, and mirtazapine was associated with more deaths in the mirtazapine group. So if all you looked at was mirtazapine, you would say, yes, mirtazapine works, but you really need the placebo group because participation in this study and in any other study, just, you know, seeing the medical professionals coming in for the visits and getting the counseling that inevitably comes along helps participants regardless of what group they're in. And sometimes there's not a difference between placebo, and sometimes even the drug can do worse than the group on placebo. That's why we have placebo controls and why it's important if a drug is going to be approved for this indication that we show that it's better than placebo. So in summary, I hope I've shown you that agitation is common and persistent in persons with dementia, and that current treatments have modest efficacy and or poor safety. I showed you results from a small trial of nabilone, which is related to THC, where we treated persons with dementia for agitation, and it showed promise. Similarly, citalopram for agitation showed promise, but there were safety issues with that medication. Two novel treatments for agitation that are unrelated to the drugs that are currently used are currently being evaluated, the NABIT trial and the CITAD trial. We still need additional evidence on efficacy, safety, and predictors of response so that we can individualize treatment to decide if these drugs will have a future role for agitation associated with Alzheimer's disease. So that's my 40 minutes. I'd like to thank the Alzheimer's Society Toronto and the TDRA for organizing this and for organizing the website and for inviting me to present on this. Also want to thank my lab, my collaborators, and the persons with dementia and care partners who selflessly participate in all the trials that we're running now and that we've run in the past, as well as my funders. And as promised, I have the QR codes in case you want more information on either of these two studies. Thank you very much. I'll leave that up for a minute and then I will stop sharing screen and Julie can take questions, and I will also be taking questions if people raise their hands.